Hi, welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor of JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along live, send us your questions and comments on Twitter. Just mention us at JAMA Network Open or comment below the video boxes at YouTube or Facebook. Before we get to our author, we have a call for papers. So JAMA Network Open is looking for papers on severe maternal morbidity and mortality. Interesting background in the editorial call for papers. Between 1990 and 2016, the maternal deaths basically doubled or more than doubled in the U.S. from 7.2 deaths per 100,000 live births in 1987 to 16.9 in 2016, which is remarkable. Yeah. A lot of the traditional causes of death, hemorrhage, infection, and management of hypertensive complications of pregnancy decreased, but what increased during the time were indirect obstetric causes such as complications related to pre-existing chronic conditions like diabetes and blood pressure, shift in the timing of U.S. maternal deaths, to later in the postpartum periods, like 42 days to 1 year postpartum, which included things like cardiovascular disease, mental health, substance use disorders, and intimate partner violence, which is really fascinating. It's always scary to me that homicide is one of the leading causes of death in pregnancy in America.
Yeah, I agree. I don't think I knew that. That's crazy.
Yeah, I think it depends. Its ranking depends on where you look and what stats you look at, but it's really fascinating stuff. So certainly it's a certain important area for a lot of reasons. So we'd love to have more papers in JAMA Network Open about it. Yeah. So changing gears a little bit, we've got our first paper today with our author, which is the Association of Simulated Patient Race or Ethnicity with Scheduling of Primary Care Appointments. And we've got first author Jana Vishnesky with us. Welcome, Dr. Vishnesky.
Thank you. Thank you for having me.
Great. Well, really glad you could join us. It's a really interesting paper. So first, tell us a little bit about yourself and why you did the study.
All right. Well, I'm a research assistant professor at the Tulane School of Public Health in the Department of Health Policy and Management. And I'm really interested in the ways in which the health system itself might be perpetuating health disparities in the United States. And so the idea from this paper actually came a long time ago. In one of my first jobs in healthcare, I was responsible for making medical appointments for patients who are living in an inpatient care facility for the homeless. So I made thousands and thousands of calls over the years and really sort of anecdotally observed that patients who had more white-sounding names, it was easier to get a good appointment for them than patients that had more Black or Hispanic-sounding names. And so that was just an experience that I had. And then later on, learning about disparities in things like wait times in emergency rooms, that minority patients wait longer there, they wait longer in the waiting room of a physician's office and things like that, really started to think that there might be something to this as well, that patients who are minorities might be having a harder time getting an appointment in the first place. So we designed an experiment to test if that was true.
Yeah, so tell us what you did in the study here. What's really interesting to me, and I think at first glance what a lot of feedback I've heard as well is how did you kind of signal the race or ethnicity over the phone with these simulated patients?
Yeah, so it turns out linguistics research shows that we're actually really good at telling things about people over the phone. We're good at guessing age, we're good at assessing race, gender, those sorts of things. And so we recruited callers who self-identified as Black or African American, Hispanic, or white non-Hispanic. And so we used them and who they were and how they sounded. And then we also had them select a pseudonym for themselves that they felt was a plausible name. So the advice we gave them was think about a cousin on one side of the family and pick her first name, and then a cousin on the other side and pick her last name, and kind of come up with something that isn't you, but could be you. And so when the callers were talking to the schedulers, they introduced themselves by that name and then just used the voice that they normally speak with, and that was how we signaled the race or ethnicity of the patient.
Okay, interesting. I'm going to welcome a couple of viewers. We have Bayo Beathach, Eric O, Jim Bob, and Gerardo Fuchik who've joined us. So welcome. We're talking about simulated patient race ethnicity with scheduling and primary care appointments. And can you talk a little bit more about voice? Because I think you explained a lot about the name in the paper, and the voice you get into a little bit, and I found that interesting.
Yeah, so when we were recruiting I don't know if this answers your question, but when we were recruiting the callers, we screened them for any sort of unusual linguistic background. So did you grow up overseas? Are you bilingual? Were you adopted by a family who's not the same race as you? And we didn't find anything like that in the patient or in our callers. And we also recruited people who grew up in an area with a significant number of people who are the same race or ethnicity of them. So we were trying to find someone who kind of represents a typical person from that group.
Okay, yeah, I think that makes sense. Okay. And going to welcome Alexei Fedotov, who's joined us as well. So then tell us what you found. What happened when the patients called for appointments?
So when the patients called for appointments, they called, they introduced themselves by name, and they asked for the next available appointment, and that was the only information that they offered when they first called. And then we waited to see what the schedulers asked of them and those sorts of things. And if they were offered an appointment, we recorded that they were, and then we recorded the date and time of that appointment so we could calculate offer rates and that we could calculate wait times for those appointments between the different racial groups. So initially we were surprised to find that Black and Hispanic patients were offered appointments at higher rates than white patients. So in calls that were picked up, 88% of the time a Black patient was offered an appointment. Compared to whites, it was about 56%. Then we started digging into the workup to that appointment offer, and we found that minority patients were much more likely to be asked about their insurance status. And when we actually controlled for insurance status, we found that significant difference went away, and there was no difference in whether they were offered an appointment. And then looking at wait times, this was the most worrying finding we found, was that there were very significant differences in the length of time that Black and Hispanic patients wait for an appointment if they're offered one. So white patients waited an average of 8.6 days, Hispanic patients waited 11.2, and Black patients waited 12.2. So between Black and white patients, Black patients were waiting an average of 3.5 days longer to see a provider.
That's fascinating.
Interesting.
Sorry, also going to welcome Scott Melito and Claudio Corradino, who've joined us.
Hi.
Go ahead.
I'm just wondering if you considered at all whether or not the location for where these calls were being made a difference in terms of the types of responses you got. I ask because, I think sometimes anecdote or experience, a limited experience, is a very powerful thing, and I wonder if that may have played into, the results that you ended up seeing, or if that's something that you've thought about in your work.
Do you mean where the study was set in general, or where the individual offices were?
I guess both, yeah.
So the study was set in large urban areas of Texas, and we selected that area because we wanted some racial diversity in that place. So we didn't want it to seem unusual that someone of a certain race or ethnicity was calling. We did, I don't know this, but I would suspect that the discrimination would be less there than it might be in some place that's a little more homogenous, although we didn't test for that. In our analysis, we did look at characteristics of the county in which the physician office was located, and tried to control for those in the analysis to see whether there were any differences in the places that the callers were calling.
Interesting. Yeah. So one of the things digging into this that was really interesting. So white patients were overall at the end of the day offered, or less likely to be offered an appointment, but they weren't asked about their insurance as much. Mm-hmm. And it seems like basically the minority patients were asked about their insurance, and then when they said they were self-pay, that they were going to pay cash and didn't have Medicaid, basically, mm-hmm. then they were given the appointments. Does that sound fair? Yeah, exactly. And so we were thinking that actually when schedulers are asking minority patients about their insurance, they're really concerned about ability to pay, and they are more concerned with that ability in minority patients than white patients. And then when they hear the answer that, oh, I'm uninsured or I'm self-pay, for this type of appointment where it's not an emergency, they're coming on purpose, and they're expressing that I know I'm uninsured, I know I'm going to have to pay, then there was more confidence in those patients, and also the confidence of maybe recouping a higher fee than they would from a Medicaid patient who pays lower rates. And so they were more likely to ask, but once they asked, they seemed more comfortable with actually offering that patient an appointment. Interesting. We've got a question from a viewer. Eric asks, was economic background a factor? Was economic background a factor? Probably. And this was a very limited study, and all of our patients had the exact same script. And mm-hmm. so if they were asked, are you employed? They all said yes. If they were asked, where are you employed? They all said a local grocery store in Texas, and that sort of thing. So if we had a larger sample size and the ability to sort of randomize economic background, we could probably see some differences, but all of our patients were the same, so we couldn't necessarily tease that out. Mm-hmm. Mm-hmm. Yeah, that's interesting. Was it HEB? Was that the grocery store? No, it was Kroger, actually. 50-50. So, my sister lives in Texas, so got to throw that in. Okay.
Yeah. This is just a minor point, but I'm just curious. You mentioned that the people that made the calls, or the 7 callers, they were able to choose or sort of make up their own names. When I assume that they're using the same name then everywhere they call. Is that right? Or
yeah, that's correct.
Okay.
Yeah,
that makes sense. Yeah, it's really, really interesting. And the other thing I wanted to ask a little bit about was, I always like these, for lack of a better term, sort of secret shopper kind of studies. And I wonder if, just in general, if, you could talk a little bit about the difficulties, trying to do these kinds of studies.
Yeah, we had to do a lot of practice because our secret shoppers got nervous in the beginning, as you say. We're not all actors, so it was hard for them in the beginning. So they got more comfortable in the pilot testing. It also became a bit dicey because our sampling from our list was actually a list of physicians, and the physicians could work in the same office. And so we tried as best as we could to not have the same office called twice. But every once in a while, one slipped in, and they'd be like, I've heard this story before. This sounds really familiar. So so we would just kind of throw those observations out. But I think those are the two of the main things. If you want to do one of these, I would do a lot of pilot testing unless you're using professional actors, because it is not comfortable for people.
Yeah, it's really interesting. One of the things that's come up before, which first of all, secret shopper, I believe is the right word.
Is
the right term
okay?
that's used in literature for this. Just the logistics of trying to figure out doctors' offices. So most of the databases are, as you said, physician, or based on the physician, not necessarily the clumps of physicians. And a lot of this comes into, for patients trying to figure out, for patients who are insured, if a physician's in network, the insurance company records of those are oftentimes not up to date. And it seems like it's easy to blame the insurance companies, which I probably do to some extent. Like you can't even keep track of who's contracted.
Yeah.
But if they're contracting with the groups and the groups have docs coming and going, it's hard to, and the databases can be out of date, things like that. I think not having everybody here is by definition self-pay or out of network. So I don't think that came up here. Have you had an experience with that, or how else that played out in your study?
No, but the reason actually that we went with uninsured patients is because we were concerned about having them say they had a certain type of insurance and running into we don't take that one, or someone trying to verify an insurance number and us not being able to give one, and that sort of thing. So I think if we did a bigger study looking at that might get it more complicated. But yeah, even figuring out who was in what office, who worked together, so we didn't call them twice was complicated. So.
Yeah, that's fascinating. I know one of the things that's come up with some of the other secret shopper ones is if they're comparing like private insurance to Medicare, Medicaid, or self-pay, that just saying private insurance doesn't necessarily mean anything because it depends whether they're in network or out of network. So the really good studies will do like different private insurances or a place where there's only one dominant insurer, which is fascinating. So what's next for your group, or what are you going to look at next?
We have a couple ideas. We really want to redo this at a national level and really be able to expand the sample size and look at a lot more things. So randomizing insurance status, maybe bringing more racial groups into it, definitely bringing men or non-binary people in as well will be good. And then looking at it at a more national scale, because again, this was just one sort of urban area in Texas. And so the generalizability is obviously limited. So that's our next step. We're just looking for funding for that now.
Yeah, that sounds fantastic. One odd logistical tangent question I have is: do you call what happens to these simulated appointments? Like, are they just no-shows? Do you call back and cancel the appointment?
Oh yeah, actually, our IRB was really concerned with this, so we never scheduled an appointment. Once the appointment was offered, we would say, great, I'll check my work schedule and call you back if I want to take it. So we didn't want to take an appointment from an office, so we never actually scheduled them.
Interesting.
That is
nice.
yeah,
That's nice. I think that's ethically probably good to not actually schedule. Hopefully they weren't holding those spots for you.
Yeah, I hope not to.
All right. Well, great. Well, thank you so much. This is a really fascinating paper. Thank you for joining us. We got one more question from B.O.B. Athach, who I'm sure I'm butchering that name. I'm sorry. With the calls, is the experimental subject the person answering the phone? I guess is the question. Well, that's not really a question. Yeah.
We went back and forth with the IRB with this as well. So we ended up consenting our callers and considering them research subjects because they were collecting some data on their own perceptions as well of the call and sort of the attitudes of the schedulers and things like that. So we consented them. The schedulers were also, I guess, considered subjects, but we didn't have to consent them. We were given permission to use deception in that. So both kind of. It's a bit complex.
Yeah. It's interesting. It's sometimes hard to classify who the research participants are in these more complicated real world studies.
Definitely.
So, yeah. All right. Well, great. Well, thank you very much again. This is a really good conversation. Really good talking about this interesting topic. So thank you.
Well, thank you. Yep.
Okay. Take care.
Bye.
All right. So moving on. What do we have next?
All right. So this is a really interesting study, factors associated with suicide ideation in U.S. Army soldiers during deployment in Afghanistan. So this was a survey study of 3,900 soldiers that were deployed to Afghanistan in July of 2012. And the investigators were trying to assess the associations of socio-demographic factors and stressors and mental disorders. And so ultimately, of the soldiers that had suicidal ideation, 44% of them also had major depressive disorder. 19% of them also had PTSD, and this was over they looked at a 30-day period, or within the past 30 days is sort of how the question was formed. And then they found a few other factors, so being white race or ethnicity, having lifetime non-combat trauma, and major depressive disorder, as I already mentioned. These were all factors that were also associated with suicidal ideation. So I think I really liked this study because I think this is sort of a population that we don't always see these types of studies kind of investigating. And so I think, the findings are, I'm not surprised, but it's just kind of nice to see some attention to this group of people.
Yeah, it's really fascinating. We've talked about this a bit before because there have been some interesting we've had some other papers on military suicide or military depression or veterans as well. And, it's, I think, a group where one is there's, I think, a lot of structural and potential to not necessarily report findings or suicide or things like that. Or if it's hidden, if somebody's, if it's like the military equivalent of suicide by cop or something like that.
Yeah.
And also just access to lethal means of suicide.
Absolutely.
As well as I'm curious if there's anything about people who are more likely to join the military because of, say, lack of other economic opportunities or educational
opportunities. Which is a stressor in itself,
Exactly. So it's really fascinating stuff, and I don't know, it's good to have more data on vulnerable populations.
Definitely.
All right, moving on. We've got an interesting paper, The Trends in Incidence in Early-Onset Colorectal Cancer in the United States Among Those Approaching Screening Age. And basically, if you look at figure 3 is where, or I guess figure 2, sorry, Eric, is where most of the money is. If you look at when patients, colorectal screening is recommended at age 50, and basically there's a big uptick in diagnosis of cancer between 49 and 50, which is not surprising.
No,
and the good news is that most of it is either in situ or localized and not metastatic cancer. And you can see that in figure 2 there. And basically, it's not like the horse is out of the barn and it's been missed, but it kind of makes sense that, screening works because the age of people are much more likely to be diagnosed in their screening year. And then they also looked at, unfortunately, life expectancy is lower at the people who are diagnosed under 50 than those who are diagnosed over 50, which you probably deal with this more than I do, or have dealt with more in your training than I have. So.
I guess that's true. I thought a couple of things about this. One, I think we're seeing more, at least reports, I don't really know about the literature behind it, of younger people getting colorectal cancer. And so I think we're still trying to understand the epidemiology behind that. But the second thing that I kind of wondered about was, whether this is sort of supporting the idea that we should be screening younger people. I think there's obviously pros and cons, I guess you could say, but I don't know. I'm not sure how that would change, because I guess if you're catching it earlier, of course, that's better, but then the false positives and all of those things come into play too. So I don't know if you had any thoughts about that. But.
I don't know. And this stuff's tough, and it's also out of my, individual professional or clinical expertise. It's certainly, I'm not doing a lot of colorectal screening in the ED. But the thing that frustrates me, it's when people are diagnosed right before screening or at a young age, it's very emotional for a lot of reasons.
Absolutely.
It's easy to attach that. I remember when the USPSTF increased the recommendation from the cutoff from 40 to 50 a number of years ago. There's big backlash, and I remember this is a terrible sample, but basically the letters to the editor of the New York Times in response to the article about that, where basically every other one was like a clinician or a public health expert saying like, this is great, the data shows blah blah blah, and we should put our efforts where the data shows we should, blah blah blah. And the next one's like, but my sister was diagnosed at 43 and that would have been missed, and it's really hard because it's the positives that stick out, and not the however many dozens or hundreds or thousands of people who get false positives or get complications from a workup that for something that wasn't ever going to cause a problem, or who knows.
Right.
It's tough.
It's really hard. I agree.
Yeah. Yeah. All right. On that note, Min Lakong's joined us. Welcome back, Min. Altaf Saidi and Beo Batak is apparently alive well in Irish, which makes sense because I cannot speak Irish.
Yes.
All right. The next one we've got is this is another slightly complicated one: the Association of Medicaid Expansion with Enrollee Employment and Student Status in Michigan. Basically, Michigan is one of the many states that expanded Medicaid under the Affordable Care Act. They surveyed about 4,000 Michiganders, which is a fun demonym, who had gotten Michigan Medicaid under the expansion in 2016 or 2017, so otherwise wouldn't have been eligible for Medicaid. And basically 54% of the respondents were employed or students in 2016, and 60%, so even more, were employed or students in 2017. And basically, if I follow correctly, the main point is that there's a bunch of states now that are trying to add work requirements for Medicaid, which I think we've talked about before.
I think so, yeah.
And basically one of the main concerns, on the one hand, the question is, are people being lazy and don't need to work and are just taking the government handout? And the flip side is how much of a burden is it going to be for people who are already eligible and working and doing the right thing and the so-called deserving poor to basically be a hassle for them and then dissuade people from getting entitlements or benefits that are going to be helpful and necessary. And I think this just adds to the kind of body of knowledge we have that most people with Medicaid either try to work, are retired, taking care of people disabled, et cetera, and that it's not just people taking a dole and being lazy.
Yeah, I wanted to ask you, I always have trouble with these studies because, as you said, that they can get quite complicated. But I wondered if there was any sort of potential for reverse causation here. I mean, I guess it would be hard, You
mean like people are more likely to work because they have Medicaid? Which is not unreasonable.
I don't know. I mean, if that's a requirement, right?
Yeah, I mean, and that's a theoretical idea. You got to get people to earn their benefits. I mean, I could see people who, because they've gotten access to, say, I don't know, off the top of my head, because I watched a TV show about bipolar last night. If you get access to your bipolar medication and then your mood is stabilized and you're able to function more.
Yeah, no, that makes sense.
Which is good, but then if you are required to work to get the Medicaid, then that cart came before the horse.
Yeah, true.
I don't know.
Complicated.
I don't know. I know where my philosophy is on this stuff, and I think trying to figure out deserving poor is fraught with peril.
Absolutely.
And from all the numbers I've seen, the work requirements are really just seem to be just a burden and a hassle, and dissuade people who otherwise deserve it to have to jump through more hoops or not get their benefits.
I agree. Yeah.
And then bad things happen to everybody.
Yeah.
Yeah. All right. Fun stuff. So moving on to more fun topics.
Yes. So this is a research letter, Association of Human Eastern Equine Encephalitis with Precipitation Levels in Massachusetts. This was really cool. So the objective of this study was to try to look at the potential association between EEE infections and precipitation during the preceding year. And so it was a cross-sectional study in Massachusetts. They used something called the standardized, or the author, I should say, used something called the standardized precipitation index, looking at essentially rates of precipitation from 1999 to 2019, and found that the 12-month lower end of that index was associated with a lower incidence of human EEE, compared with the 12-month higher end of that index was associated with a higher incidence of human EEE. So, the point being that potentially precipitation, rain, right, it brings mosquitoes, and that may have resulted in more cases of the disease. Of course, the study is limited by the fact that there are a lot of other factors that go into play, including things like temperature, climate, all these kinds of other notable points. But I kind of thought it was interesting. I trained in Massachusetts. We definitely saw EEE, and this past year actually there was a fairly high number of cases actually that occurred compared to prior years. And I think that the author actually notes that one of the highest years of precipitation actually it's sort of interesting to see there were also a lot more cases too. Yep. Again, you can't really say that one caused the other, but with this observational data, that's still something kind of interesting to think about.
Yeah, it's certainly hypothesis generating. There's some face validity, and mosquitoes basically the eggs live in standing water. The way they described it is when there's more rain, there's a year-round larval habitat.
Yeah.
I mean, I've had in my limited experience alone just, I remember one somewhere where my neighbor's backyard had a kids pool that
Yeah.
like rainwater collected in, and we got a
Yeah.
ton more mosquitoes, and then
Yeah.
they got rid of the rainwater, and there were fewer mosquitoes that summer
Yeah.
after that. And it makes sense. The other two things I liked about this is he talked about the passerine birds, who are one of the natural harbors, which is some taxonomy, large taxonomy of birds that includes wrens, finches, and other songbirds. I hadn't heard the term passerine. One of the little quirks I love about this is that it's a single author study.
Yes.
So instead of a lot of like the royal weaves, it's like just like straightforward. I hypothesized.
I know. I loved that.
And I just think it's funny sometimes when you realize like, wait, this is just somebody talking about the research. It kind of brings you back to like the 17th century like Royal Academy, where it's just like a bunch of like rich dudes sitting around saying like, hey, like I did this study and I like went to my the wing of my castle and like this is what I hypothesized about.
Yes. I will say though, I think this fits kind of nicely into, there's a lot of research ongoing right now looking into the relationship between climate change and vector-borne disease.
Yep.
So just be on the lookout for that.
Yeah.
More of that, I suspect.
Speaking of things to be on the lookout for.
Yes. So this is another research letter, Trends in Anogenital Wart Diagnoses in Connecticut, 2013 to 2017. So the background behind this is that in 2013, Connecticut became one of the first states in the U.S. to achieve what they call moderate, so the greater than 50% uptake of HPV, human papillomavirus vaccine, in individuals of both male and female individuals. And so the investigators aim to measure trends in the incidence of the diagnosis of anogenital warts, which is caused by HPV, in the setting of achieving this sort of uptake of vaccination. And so this was data from Yale New Haven Health System, 21,000 individuals.
Yep.
Overall, they found that the proportion of incidence anogenital warts diagnosed actually decreased by almost 65% over the study period.
Yep.
And it's interesting because initially it wasn't sort of equivalent among males and females, but actually after a year it then became essentially, they noted that it was both, that the decrease was both in males and females. The figure actually demonstrates this decrease in incidence, and they also kind of looked at younger subgroups and those that were vaccine eligible and saw sort of similar trends. So very interesting, very, I think, again, we can't make too many, I don't want to make too strong of a conclusion from this, but it's always nice to see the power of vaccination. Yeah,
I mean, and this it makes sense in a lot of different ways. It also resonates with a lot of other things that, I don't give people HPV shots at work very much, but trying to talk to people about complex risk assessment, our brains are really bad at looking forward for that.
Yeah.
I have a pediatrician friend who I'm forgetting who it was. I'm going to have to look it up and find the tweet. Who said, you try to talk to a 13-year-old boy about these shots that are going to prevent cancer, and there's no way, all of us are bad at that. We've talked about this before, how few adults get flu vaccines and all that stuff.
Right.
We say, all right, but it's also going to stop you from getting warts on your penis. And oh, yeah, sure,
That's
sign me up.
Yeah.
So, I think it's a very much more immediate, deliverable, visual, I don't know, guttural thing.
Yeah, no,
visceral reaction. So
that's true. It's the manifestation which may have, which may be more powerful for people.
Right, and it's also the kind of thing where just HPV, was it 3,000 or 4,000 women used to die of cervical cancer a year from HPV-related cancers, and we can cut down a huge number of those. And even if it's by happening to decrease genital warts, great.
Yeah,
good
agreed.
for everybody. Win-win-win.
Agreed.
All right, a couple real quick hits from some other interesting papers. Going to welcome Karen Gibbs has joined us. Welcome. Just some really brief takeaways. Not going to get into methodology or anything, but number one, patients who are more mobile in the hospital are more likely to go home versus a nursing home after their hospitalization. States with more vaping regulations have lower rates of vaping. Again, that we've talked about that before. That can easily go in either direction, but it's interesting. There's an interesting study in Canadian nursing homes, where they looked at the work environment and how rushed or how much the staff or the care aides had to rush or feel like they were understaffed or didn't have enough time to get things done, and they were more likely to have missed tasks or rushed care tasks that were not done well, which again makes sense.
Yeah.
And also this one's way too complicated to talk about, so I'm just going to briefly say, but they looked at they did proton magnetic resonance spectroscopy and MRI imaging of fetal brain development, and found that maternal psychological stress was correlated with findings in with a prenatal maternal with fetal brain growth and cortical maturation, biochemical development.
Oh no!
So there's all sorts of different studies that show relationship between stress and development, and this is kind of looks at some intermediate markers, but things that all we know are associated with things. it's just interesting to really kind of see. Again, this is more on the basic science side of
Yeah,
stuff, but
yeah.
really interesting.
Definitely.
All right. So on that note, thanks for joining us. Of course, join us next week, Tuesday the 11th at 3 p.m. Central Time. Get these papers and more at JAMAnetworkopen.com, where everything is free and open access. You do not need to log in unless you want to make a comment or set your recommended article preferences. Follow us on the usual social media channels. Listen to the author segment of this podcast or this video on podcasts, iTunes, Stitcher, wherever you get podcasts. And take care.
That's great. Take care, guys.
All right, thanks.